Right, moving on to the next example, which I was just given a paper about literally 2 minutes before we started this session. And it's about rotavirus and intussusception. So rotavirus is an infection that causes severe gastroenteritis, and in the United States about 3.5 million cases a year happen in children under 5, so it's very common. It leads to lots of hospitalizations, about 50,000, and in a given year in the States it could lead to around 20 deaths. So very common infection, very rare but serious potential outcome. So in the late 1990s there was a new vaccine against rotavirus that was introduced and to be given in 3 doses. So the pre-licensing trials suggested that intussusception may be a possible safety issue. This is a problem where the intestine can fold in on itself, and this can be very painful and in some instances can be very dangerous. In the trials, the incidence of intussusception was 0.05% in the exposed and 0.02% in the unexposed. But because these are trials, and even though they'd got 15,000 people in the trials, this wasn't statistically significant. So it's the kind of thing that we would see as a signal of a potential problem, but unconfirmed. So it remained a safety issue, and not long after the vaccine was licensed, there were spontaneous reports of intussusception. So this became a big problem, and the vaccine was initially suspended pending further investigation. So there was a study done using data from the US, and it involved the discharge diagnoses from 19 different states in the US, and involved hospitals with about 75% of the intussusception cases in those states. And the investigators did both a case control and a self-control case series analysis again. So the controls were children without intussusception who were matched on age and who were born in the same hospital as the cases. So the medical providers interviewed the parents of the cases and the controls to determine both their vaccine history and other covariates that they would want to adjust for. And this is a paper that was published in the New England Journal of Medicine in 2001. So here was the study design. So they had the date of the rotavirus vaccine as the start of the exposure, or the start of the hypothesized increased risk period. The first 2 days following vaccination, days 3 to 14 and days 15 to 21. And so this was the period of time that was separated out from the rest of the baseline time. And so remember that all of these kids are going to have intussusception, and the intussusception could happen at any point during the observation. And we're just trying to see, is it more likely to happen during this period? Yeah. They also allowed for the children to have a second dose of the vaccine, or a third dose, and then use the same principle of separating that time out from the baseline time. Okay? So these are the results they found in their analysis. And so interestingly, they did both the case control and the self-control case series. So in the case control study, with their 429 cases and 1,700 controls, they found an odds ratio after the first dose of 22. Now, if you work in pharmacoepidemiology, you never come across these kinds of odds ratios. This is enormous. So clearly a massive association with the vaccine. The subsequent days 3 to 14 after the second dose, the odds ratio was much lower, but still increased. The self-control case series, which involved just 432 cases, was pretty similar. So the rate ratio here was 29.4 during the first 3 to 14 days after the first dose, whereas it was 6.8 after the second dose. Okay, so both study designs pointing in the same direction, quantitatively slightly different, but both leading to the same conclusion that there was likely to be a major problem with the rotavirus vaccine and intussusception. Now, the study investigators, I think, were right in doing potentially both study designs, because the two designs would have different strengths and weaknesses, and so it's useful to see that whichever approach they took, the conclusion and the answer was pretty much the same. Okay, so I think that increased confidence that their findings were probably correct. Okay, so it was strong evidence of a causal association. They estimated the public health impact of both rotavirus and also potentially the problem of intussusception. So they figured out that between 5 and 10,000 infants would have to be vaccinated to generate one additional case of intussusception, and that this could lead to 350 to 700 extra cases of intussusception a year in the US. They decided that because of this, they would withdraw the vaccine altogether. And their reasoning was that although 50,000 children a year were hospitalised due to rotavirus, that this was actually generally relatively simple to manage through rehydration in the hospital. And this is how they weighed up the risks and the benefits of the vaccine and decided what was the best thing to do. Now, interestingly, you could have come to a different conclusion if you were working in a setting where the treatment of rotavirus may be very different and may be very difficult. So if you didn't have the same kind of healthcare and hospitalisation was relatively simple and available, you may have decided that the risk associated with rotavirus was worth it, and so you would actually continue to vaccinate. Here, like I said, the agreement between the two methods was very useful because it increased confidence that the estimates of the effects were correct. Okay, any questions about that one before we move on?
So what if the result from case control and the self-control didn't agree? What would be the conclusion?
That's a really good question. So every time we decide to look at things in more than one way, we need to be careful and think in advance, how might I interpret differences? And often, if you're comparing between a self-controlled study and a conventional design, I think the two things that you would think about carefully are, in the conventional design, I may worry more about between-person confounding, and what do I believe a priori that confounding would do to a result, and that then may help me to explain differences. But at the same time, there are some major assumptions that we must make in order to use a self-controlled design, which I'm going to come on to in a minute. And I would need to again think in advance, if I believe I could break those assumptions, how might it affect my result? I'm not saying that this is easy to do, but this is the kind of thinking I would want to do in advance, just to try to preempt any problems with understanding differences. I think often people will say you should only do one design to avoid this problem. And I'm not sure that I believe that, because the problem is still there. It's just that we don't know about it. And I think that can lead us to have a false sense of confidence in our findings. But yeah, you definitely would need to think carefully about how to interpret that. Yeah. Okay.